Thanks to our panel for joining us today. It's certainly an impressive lineup. Thank you all for making the time to speak with us. As you know, we're undertaking important research on the rights and the roles of people in Australia living with cancer. So it would have been quite remiss for us not to have spoken to people at the coalface of the clinical setting. A lot of the conversation that we are having with people centres around the clinical relationship with their treating oncologists and haematologists. So this important conversation is contributing really valuable information, and we thank you very much. And to the people listening, I'm sure we'll all get a lot out of this conversation. We do have a lot of pre-submitted questions. I'll just throw to you all now with a general concept, which is there has been a strong emerging theme around the research we've conducted so far into the rights and the roles of patients, and that is that the patients have a right to be informed. How do you balance your experience and scientific knowledge with patients' desire for information? Are there scenarios where this is problematic as a treating clinician? Christopher, would you like to start off that conversation?
Thank you very much for the opportunity to be involved in this important webinar today, and with pleasure, I represent the Private Cancer Physicians of Australia, but also I'm pleased to give my indications of this important issue as a clinician in private practice in a regional area. And of course, it is always a tension, and it does take time, as Richard Vines importantly said in the last webinar, to involve everyone and give as much information as possible. I think from a private cancer physician perspective, one of the values of the private system is you can potentially do this and you have a one-on-one relationship with your patient. I would stress the importance of shared decision-making in this process and how crucial that is. And I always strive to give as much information as I can to the patients. We've got so many challenges in this as our cancer treatment world becomes more sophisticated and difficult. Providing the information is more challenging. The health literacy of our patients is crucial and a challenge for them to understand what we are saying. But if you can focus on the patient, and I know patient-centred care is the topic of this discussion and the difficulties that places, and it's not just a word, it is a concept that we try and address. But shared decision-making is certainly my goal with every consultation.
Thanks, Chris. John, would you like to add to that topic?
Yes, thank you, Steen. I guess I don't have a lot to add. I just make one additional comment, perhaps, because I don't think any of us would dispute the fact that or argue with the fact that it is a patient's absolute right to be informed and understand what's the disease that's affected them and the implications of that and treatment. What I say to patients that are going to see other doctors sometimes, I wish I could apply it myself as often as I say it to others, and that is that if you go and see a doctor and you don't understand what's been said to you, then the doctor's failed. And I say that, as I say, because I think I fail a lot, but it is a matter of trying to provide the information that doesn't overwhelm. So, you can say, well, information is a good thing, but it's not an absolute phenomenon in the sense that it can overwhelm, it can frighten, it can cause anxiety. It can do all sorts of things which we not necessarily things we want to happen, but equally, so on the one hand, there's a sort of wish to provide the information, and as Chris said, we provide as much as we possibly can. On the other hand, you have to be able to be aware of what's happening on the other side, and it gets complicated when you've got a family where the patient maybe doesn't speak English. The husband is frightened out of his wits. The son's a scientist. and understands all of this, and who do you talk to? You know, you're trying to reassure the patient doesn't even know what's sort of going on because of the language issue. The husband does, but he's scared and frightened. The son, who's a student or a scientist rather, understands this extremely well and has a different framework. That's the balance. But in the end, the fundamental principle that drives this, patients have every right, total right, to know what's happening and to understand what's happening, not just to know it, but to understand it and to be able to use the information to make decisions for themselves. But the context of this is sometimes more complex.
That's really great. Thanks, John. You painted a really vivid picture of the reality of a clinical setting with a distressed family and other complex features there. Talking about decision-making, shared decision-making specifically, Claire, would you like to talk a little bit more about some of the challenges that go along with that, given your expertise in medicine and genomics and treatment protocols and sharing the decisions with people who, as John said, can be quite distressed and have various levels of health literacy?
Sure. Well, I think taking things a step further from the picture that John has painted, what we all know is that it's a series of conversations, and you have to be able to take that next step of explaining to a family that a series of conversations is going to have to be required to be able to get from point A to point E. And there are a whole series of issues that need to be discussed. And generally in cancer, there are various time points in the journey when different things need to be tackled. Sometimes we have standard approaches to therapy. Sometimes they're complex even at the beginning, and different issues arise. And so you have to try and pull it apart in bite-sized chunks so that you can address different points at different times. So it's incredibly important to try to be able to break that down for a patient and their family. Also within the family, to try to work out who is going to be the person who's kind of maybe the speaker, or not the keeper of the information, but the person who is perhaps the most health literate and who will be helping to explain things, and to try and have a track for the information through the family, and certainly to ensure that adequate interpreters are available. There will be conversations where it's essential that a professional interpreter is available, and sometimes it may be helpful to ensure that you have an adequate family interpreter available, because sometimes some families will prefer that. But as I said, at times a professional interpreter has to be sought, and it has to be explained to the family that that's important. So if we now, I think you wanted me to talk about genomics. I mean, there are very complex genomic issues to be discussed, and there have been and are ongoing, some very helpful surveys about genomic information and how patients wish to receive that information, and whether they're capable of interpreting it. And of course they are, and upon what level of genomic information is appropriate, and different levels will be appropriate for different patients. And I think that the conversations we have with patients are held at different levels depending on what information patients will want to receive. I work in a family cancer clinic, so we've been used to this for many years, and it is possible to explain concepts in different ways. So we're working through that, and as a community, we're working through that. As Kate and Richard know, I instigated the Consumer Advisory Panel at the Walter and Eliza Hall Institute so that they would help us, so consumers would help us advise our Medical Research Institute about how the community wants to have that conversation with scientists, so basic medical researchers, because genomics is such an important part of our everyday life now. It affects not just medical health, but what we eat, and all aspects of our health, and the air we breathe and the water we drink and so forth. So I think that literacy about genomics is something that our community is grappling with every day. But if we bring it back to decisions that we have to make about cancer and cancer treatments, we can simplify it, and patients are very willing to have that conversation about what test do I need to determine what treatment I should have, what is funded by the government, what is not funded by the government. These are essential conversations. And the problem is, if things are not funded by the government, when should we be having that conversation in a public system, which is where I work. So, I'm sure we're going to talk more about that in the hour that we have. And I think that it really does come down to, in a certain extent, the patient you have in front of you. Not all patients necessarily want to have that conversation, but I guess we're here to talk about that today.
Thanks, Claire. That's really interesting. We certainly will touch on prescribing and medicines and funded and not funded treatment modalities shortly. Grant, I just wonder if you could pick up on, I guess, what we've already set the scene here, which is information and a patient's right to know. I imagine increasingly over the years, you all have seen people coming into your clinical setting who have done their own research. They might come and they have searched extensively, have some good information, have some less good information, and perhaps even have some suggestions for you on what should happen next and treatment modalities and things. How do you juggle the more informed people that come in with good decision making?
Yeah, thanks, Christine. Fantastic to be involved in the webinar today, and thanks to the National Oncology Alliance for this series. I think it's just tremendous and is really going to inform the process moving towards a national cancer plan. So thank you. Yeah, so you raise what is an interesting and at times can be a challenging situation. Now I'll speak personally, and then I'll speak more generally for clinicians. So I've always think that personally I've got this, it's pretty easy for me to personally deal with patients that are extremely well informed, come in with 3 manila folders that are stretched up to 6 centimetres each with published articles. For me, I actually find personally that easy because I focus predominantly on one disease, the disease of melanoma, and I'm extremely well linked to the latest knowledge through my colleagues globally, and I've got a lot of knowledge that's not in the literature as well as all the knowledge that is in the literature. So I actually find that straightforward. What I think though is really challenging, and absolutely agree with the concept of patient-centred care, of course, and joint decision making, and that is when that patient presents to someone who perhaps doesn't have that depth of knowledge. And I think that's very challenging for the clinician. And actually the appropriate thing to do there to give the adequate information and the best opinion for the care of that patient to enable true joint decision making is actually often for referral on to a clinician that perhaps has deeper knowledge in that specific area. And I would encourage that, because it's actually for those of us that do specialise in one specific disease or a narrow range of diseases, we have all that information at our fingertips and more. I say to my patients that I know the unpublished data that is yet to get into public domain, which I think ethically, as a clinician that is committed to the very best outcomes for my patients, I use that information in informing my patients as to the best care. So I think it depends on the context. And just one other comment I'll make before we move on about health literacy. It's come up from Christopher and John and Claire. So very important. So it took me some years to actually understand why I routinely get the patient to retell me their history rather than just relying on the referral letters. And the reason I do it is that you really get to understand the level of health literacy of the patient, and then they're often accompanied, as we've already spoken about, by support people, and that conversation often is a round table, and you assess, as I think John said really well, if you've got the one family member that's a scientist and the patient is not speaking English and you need to use an interpreter, well then you're assessing the health literacy of everyone that's involved in supporting that particular patient. So health literacy is vital, and one of the actual enjoyable things as a clinician, and like John, I make mistakes all the time on communications. But one of the things that I actually do enjoy is dealing with patients at the extreme, some patients with poor health literacy, where the conversation is different to a patient that walks in with that 3, manila folders full of information.
Yeah, thanks, Grant. Absolutely. I'm sure that's unfamiliar to all of us, even in the supportive sector. Thank you. I think we need to give some time and real estate to treatment and treatment modalities and prescribing, if we can all just pivot a little bit that way. Do you think, Christopher, perhaps we could start with you. Do you think prescribing in Australia is too restrictive? Specifically, does clinical expert decision-making come in and informing best practice become bound somehow with the systemic barriers that are in place?
Well, yes, thanks very much for that easy question. I have to declare my conflicts, of course. I'm involved in the Medical Oncology Group, MOGA, Oncology Drugs Working Group. We meet with the PBAC quarterly to try and address this issue from a clinician perspective, but also, as you know, clinicians representing our patients. And what a challenge it is to deal with the body such as the PBAC, who have this pot of money that they talk about, and then they have to essentially what I call rationing the services. And there is, it's clear that is what is happening, even though they don't like using the word. To my point of view, it's clear that all patients can't have all the drugs that they need, and the patients with rare cancers are clearly disadvantaged in that argument, and unfortunately probably always will be unless the system changes radically. We all know patients. There's patients who sit in this chair here, so this is in my office, who will come in and they'll say, well, why can't I have X drug because the other person does? And I said, well, that is the system with which we are dealing with. So as a committed clinician to this issue, my role is to do what we can to inform the decision makers as best we can, using the evidence. Let's face it, we are evidence-based clinicians, to try and drive change. And it's little by little, and the faces of this webinar, the people I know well, are also committed to this. And as clinicians, we can represent a group. The PBAC welcome that. Of course, decision makers welcome the views of the patients themselves, and Rare Cancers are a model group in taking this issue forward, and that's why we're all here today to get dedicated to it. But there's definitely difficulties in the process, but you'll find us clinicians are working hard to address it.
Thanks, Chris. John and Claire, I'm not sure which of you would like to pick up on this one, but we did have a question pre-submitted, which I suspect is from a clinician who says that there isn't any particular training or knowledge around having difficult conversations with non-subsidised medicines and families who may benefit from them. And is that something you need to, I guess, be upskilled on as clinicians, or I guess just what does that conversation look like from your side of the desk?
John, you're muted.
Sorry, do you want to kick off, Claire? I'm happy to comment as well.
Yeah, sure. So certainly in my experience, what I spend a lot of time doing is, so as a clinician scientist, I will often identify a patient in my area of expertise. So for example, rare gynecological cancers who I believe has an indication to receive a high cost drug because their cancer may be matched molecularly to a particular drug. So then we have a task trying to obtain them that drug. I may attempt to get it from the particular company who makes the drug. And if we are unsuccessful there, but we really think it's worth the patient trying to find the money, we'll certainly try to think whether we can fundraise through Rare Cancers Australia with their supportive structure, the fundraising structure. So that whole conversation, even raising it, can clearly be potentially very distressing for a patient. So I will think long and hard about going down that path. And someone who doesn't have my level of expertise, either in identifying the match for the drug, having a relationship with the drug company, having a relationship with Rare Cancers Australia, and having being used to going through this whole discussion with a patient just may not know where to start. And in fact, I think it was Mogga, no, or maybe you, Chris, who got me to give a talk to trainees, so medical oncology trainees, to give my 10-point plan on how I write the email to the drug company to try to get the drug in the first place, because I certainly do write a very long email in that regards, and it usually takes me an hour for one of these cases, because I do find I have a much better success rate when I put all the literature into the email and all of the, you know, reasons why and so forth. So these cases are not easy. And when I say case, I apologise, because obviously there is a person at the centre. But the reason I do say case is because it's not just the person. The person is at the centre, but it's actually the literature, the data, the rules, the reasons why, every argument I can muster, the precedent, you know, everything about it, because I need all of that to try to increase the chances of getting hold of the drug. But what you asked me about was the conversation. So it's all of that that gives me the comfort, to have the comfort zone and the equilibrium to have that conversation with the patient. So it's probably the experience of having done that many times before that gives me the comfort to have it again. But what's, I think, the sticking point for the patient is some patients may have some money to start if we have to go down that route of paying. And that can help because it means they can actually start the process. What we're really trying to do is often fundraise, perhaps through Rare Cancers Australia, and I know the process with them, and introducing them to you, Christine, and then explaining to them how that works. And surprisingly, you know, they may be surprisingly successful at getting the money because it's not their nearest and dearest. It, as you've explained to me many times with social networking, it's actually random people out there who are friends of friends with the way Twitter and Facebook works. You never know who's going to donate. So it actually works quite well, but you have to have the, you know, understanding to be able to explain that to people. I know it's a long answer, but that is actually how it works in my experience. So it shouldn't work that way. I totally agree with everything Chris said. We should have, you know, a better way of funding these people through the PBAC. And so trying to get 10 of something and then get it to the PBAC and get that rare indication funded, that's what we need to do with bringing data together. And that's another question that I hope you'll ask me about.
Richard, do you want to chime in?
Yeah, please. I just wanted to let you know that Professor Fran Boyle is on the call. We didn't think she could make it in the first instance, but she's now here. So, and she was keen. She sent me a message. She's keen to comment on the communication challenges. Look at that perfect timing. Fran has magically appeared. So I'll just it's sort of like perfect. I'll leave it back to you, Christine. I just thought I'd be a little bit disruptive for a moment, but it's great. Thank you.
Welcome, Fran. Welcome, Fran. Please do join the conversation.
And if I was to if I had to do just one little introduction to Fran, it's like she is a legend in the space, particularly of breast cancer and medical oncology. So we're delighted to have her, and it dramatically improves our gender balance on the panel. So it's exciting for all sorts of reasons.
Excellent. I'd love to just, I'd love to talk about communication skills training anytime you like, but there are a few initiatives that are underway at the moment that might be helpful to know about. One is a project from the University of Sydney looking at communication skills for dealing with different people in the room. So the family, not just one person, but 2 or 3. And that's called eTrio. So it's an online training program, and it's being run by Ilona Yuraskova. Many of you would know. So that will be coming to an oncology unit near you soon, because we've had to flex a lot of our communication training to be deliverable online. And in some ways that offers opportunities to reach people who are in clinical settings we didn't have before. The other one is that there are modules on training talking about high cost or unfunded therapies. And one of the really important things we discovered investigating this years ago was that it was very important to put the money up front. So it's very important to start with saying, here's a $5,000 test that can do blah, blah, blah. Are you interested in hearing any more about that? what doesn't work for the patient from an emotional point of view is saying, oh, this is a great test and it can find a drug that's just perfect for you, blah, blah. Oh, and by the way, where's your MasterCard? So it's really important that you start with the money. And the challenge is that means you need to know what the money is. So you need to know what a foundation medicine test cost. You need to know whether we can get it done at Peter Mac more cheaply. With the drug, you need to know not just how much a year would be, but how much a month would be. Because for many people, they get a month into it and they get a rash and they stop taking it, or they get 2 months into it and it doesn't work. And so they haven't spent $50,000 on the drug. They've spent, okay, $5,000, but it's very important to know the incremental amounts of money that something might cost, because people don't buy a year's worth of, Keytruda. They buy it dose by dose. And that does actually influence the crowdfunding, the people being able to come in and help, because there's time. It isn't the case with drugs, unlike surgical treatments, that you've got to have, 50 grand up front. It doesn't work that way. I'd also like to echo the wonderful help that Richard has been to me for my patient who was the patient from hell and decided that she needed to have a drug that was neither TGA approved or in the country. And you'll be pleased to hear, Richard, she's having her first dose right now and everything's going fine. But a friend turned up with 150 grand to get the drug into the country. So, it's not going to happen all the time, but sometimes the patient from hell has got a really good perspective on what's a useful thing. And there's a wonderful book called The Patient from Hell, which a patient gave me many years ago, written by a climate Scientologist called Stephen Schneider, who got a rare form of lymphoma and worked using his knowledge of mathematics and modelling with his cancer team to actually get a surprisingly good result and be cured of his disease. And it's a very useful book for clinicians to read, because what it talks about is knowing enough about your patient's background to work with their strengths and to really be able to not be in a position where you're knocking them back all the time, but where you're actually going, right, that's a good idea, excellent idea, let's work with that. And that changes the whole conversation, I think. So recommended reading.
Thanks, Fran. Can have a book group. John, would you like to talk? I'm not going to prescribe a very detailed question for you. Can you give us your viewpoint on patients' rights meets technologies and treatments which are to varying degrees available and not available to Australian patients?
Sure, thank you. I guess I just echo the conversations we've had so far, but I just perhaps make a few additional comments. I think we did the research, it must have been about 10 years ago, where we asked oncologists whether they told patients about high-cost drugs, the availability of high-cost drugs. But this is at cost to them, I mean, rather than cost to the system. And at the time, I recall that about a third of oncologists said they didn't tell patients about it. And although that was somewhat met with horror, I think the reason was pretty obvious when you think about it. They thought by telling people about things they couldn't afford, that they would cause greater anxiety and greater stress. But there was an editorial that accompanied that particular manuscript at the time, or that article, in which we basically said, look, I think every patient has the right to know what is or isn't available. And the question of providing the drug, supplying the drug, is a second tier question. So sometimes you can't get it, sometimes you can, sometimes it's available on a clinical trial, sometimes the friend, as Fran said, has got the money, and sometimes they can afford it themselves, no matter how they're dressed. So I've always taken the view, really, since that time, that I always tell patients what is available, and I tell colleagues and friends that are seeing oncologists to always say, if money was no object, what would you recommend? It's a provocative question, because it may end up in a situation where there is an effective drug and they literally can't get it. But as I say, I see it as a second-tier question. I think the first thing is to know what may help or may be useful. And I think the second part of it is how do we access the actual drug itself? And there are many ways that it may be accessed. And so I deal with them in that way. And I think it's important that we tell patients what the opportunities might be. I think it's also a lot of clinicians are not necessarily aware that a drug on the market is a drug on the market, and the market is a global market. So as soon as a drug is available anywhere in the world, at least when it's approved by, an English or a European or particularly the FDA, which tends to be the fastest, as soon as a drug is available, approved rather by one of those regulators, it is formally on the market and it is available, and it can be used and administered in Australia without any difficulties apart from potentially cost. And as I've said, the cost issue for me is a second-tier question. Maybe I'll stop at that point there, I think.
Thanks, John. Appreciate that. Grant, I've got a question here from Dr. Mike Freelander. Is the rationing appropriately reflecting the rights of patients? Richard Vines. Is there any concern that patients are missing out on best practice treatments because of delays in our regulatory system?
Yeah, thanks, Mike and Richard. I think it's an important question. It was interesting, Christopher, using the term rationing, and I agree with Christopher that effectively that is what is done. And to really think about it very objectively, it's clear that the health budget is not infinite, and so there has to be some degree of rationing of spend in the health budget. I often say to my colleagues overseas that wonderful thing about the Australian system is that once medicines are available on the pharmaceutical benefits scheme, there is at least in a standard procedure access for all Australians at reasonable cost to that, with certain socio-economic barriers for some groups and some individual patients at times that perhaps are not aware of and getting to healthcare. But by and large, it's a terrific system. Once something's listed, patients can get access at a reasonable price. So I think actually there is rationing. We have to have some rationing because we can't have every possible innovation that comes through is going to be available to everyone because of budgetary constraints. That's reality. Are we missing out? So does that mean that patients are missing out? Well, unfortunately, yes. In Australia, I often think that what matters is when a drug is listed on the pharmaceutical benefit scheme for reimbursement at reasonable cost. So the Therapeutics Goods Administration, quite rightly, made submissions recently to the parliamentary inquiry, reinforcing that actually the timelines for approval for a drug to be marketed within Australia and approved by the TGA are pretty good by world standards. But that's actually not what matters to patients. What matters is when at an affordable cost you can get access to a drug, and that is PBS listing. And often we are delayed compared to other jurisdictions, particularly United States, Switzerland, Germany, even in instances now where patients have had access in the UK before Australia, despite some of the systems that they have in the UK. So I think yes, patients do miss out, and that we need to continue to think and reform, the reimbursement, the support for drugs, new medicines, and other innovations in Australia to ensure that patients get rapid access. So we, as clinicians, the National Oncology Alliance, particularly patient advocacy groups, all of us need to continue to get the system reformed for more rapid access, because I think it is a problem.
Christine, it's John here. Could I provide a slightly slightly different perspective to Grant anyway? But I mean, not that I disagree. Well, it's this question of, so there is definitely rationing occurring. There are patients who are missing out, and there are long delays between approval in a major jurisdiction around the world, or indeed even by the TGA, and access by a patient. So rationing is occurring. There are something, at last count, there were over 30 drugs that are not even available in Australia for the treatment of cancer because companies don't see the value in bringing them here. But I think I'd just like to, at least for the sake of a discussion, is to say that I'm not sure that we need to say, I honestly don't know that we need to say that rationing is inevitable and rationing must occur. If we look at some of the drugs that have been delayed in Australia, they have been available in 30, 40, 50, you name the number, countries around the world, and have not been available in Australia. They're going through the system, they eventually get approved, and as Grant says, when they get approved, we've got a great system. It was created to allow equitable care, and it does create that. But it's the 2 or 3 or 4 or 5 years, and sometimes longer, that patients don't access it, and there's no second chance. There's no going back, right? That's the problem with cancer. It's a bit different to other conditions that are chronic over many years. And they're important conditions. They're serious conditions, whether it's ulcerative colitis or motor neuron disease, they're really important and they affect people's lives dramatically. But in the cancer setting, when the patient has early disease and then it becomes late disease and then advanced disease, there is no going back. And I don't agree that we need to think about rationing as sort of somehow, and I know Grant wasn't saying this, but if you look at the countries that we're comparing to France, we're comparing to the UK, we're comparing to Germany, we're comparing to Switzerland, we're comparing to countries that we'd like to think we've got an equivalent standard of life, an equivalent society. And yet here they are, we're 40 countries down the track and the drug's not available. And it's available in other places. And there are innumerable examples, not 1 or 2. So look, rationing is part of life in a way. I accept that. And I'm not really taking issue with Grant, who I have enormous respect for. I just feel like I don't want to let the pharmaceutical benefits and the government off the hook. It doesn't matter what persuasion the government is. It's happened under Labor, it's happened under Liberal governments. But the fact is, we are a Western society in a developed country with a high GDP per patient, and we shouldn't have to ration drugs in the way that we do. I'll stop at that point and get off my high horse.
Claire, I know you want to chime in. I just want to ask you to, I guess, put in perspective this conversation about access and rationing and where there is a paucity of evidence and where something might work for something else in the lens of the rights of people living with cancer. What is your view there?
Yeah, I just like to put it in the context of rare cancers, particularly because more than half of gynae is rare. And so unlike for melanoma, a pregnant pause, unlike for breast cancer, which is where I came from, and breast cancer is the most magnificent example, and now melanoma is too, where there are whole, programs of drugs which allows people to survive. In gynae cancer, we have carboplatin and paclitaxel, and we wheel that out again and again and again. And even where we have PARP inhibitors, they are only approved for people with BRCA1 and 2 mutations, and we had to fight to get them for somatic as well as germline. We don't have them approved for anything else. Across Europe, UK, and America, they are approved for platinum-sensitive cancers, only for BRCA1 and 2 mutant, nothing else in Australia. Now, that may not mean much to people on the call, but it is only a fraction. So rare gynae cancers, the reason you see me give that big example before about what I try to match is because we just don't have targeted therapies approved. So we are living in the last century. So I'm just backing what John said. So for patients with rare cancers, it is what Richard says. We are a separate world in cancer management. So we need strategies around taking evidence to the PBAC, and that is about getting money to fund data integration. We need to be able to get data together so we can take evidence of who is responding to what. So there is a lot of work to be done so that we can get evidence together and we can change the way patients can be viewed it has to be evidence-based, and I believe we can do it. We can make a difference, and we have to. And I have the greatest respect for what NOAA is doing, raising awareness, saying this is not good enough. We have to make a difference, and we have to all come together with our individual expertise to make sure that we change the way we are practicing oncology based on clinical trials, but small, smart, nimble trials where we have to try and, get patients onto the right drugs, get the data together in small numbers, and then make sure that the PPAC is able to take note of smaller numbers. We know they're willing to look at this, but we need all of this to happen faster. We just can't have these terribly slow approaches. And I used the example of somatic BRCA. It took a long while for that to be approved. It shouldn't have taken so long.
Thanks, Claire. I think that we could have a whole session on data and nimble clinical trials. Yeah. I couldn't agree more. We have an overarching question for each of you, which we'd really love to get your viewpoints on. We've got just 9 minutes left. So if you could ration that out between you, we'd really love to get your views on what the rights are what the question specifically says, what are the rights of each of us when and not if we become affected by cancer? What are society's responsibilities? What is the social contract? Grant, would you like to start?
Yeah, look, it's a terrific question. So what's the social contract? Look, I'm proud to be an Australian because I think as a community, we do care for each other as a fundamental underlying ethic of our society. And part of that is a social contract to look after, the sick, the frail, and, we now have a lot of new innovative technologies that are expensive. And so we as a community need to inform our decision makers and leaders that, the care of vulnerable sick people is a priority, for us. I think it's a part of what we are, and that is the social contract that we, as a people have, to inform our leaders and decision makers.
Thanks, Grant. We are hearing more and more the interchange between a patient's rights and human rights in this research that we're conducting. So thank you for touching on that point. Chris, would you like to add your perspective on the social contract of responsibilities? You're just on mute. Yeah, thank you.
I'll focus as a clinician dealing with the individual that sits in this chair, who is also part of a biopsychosocial model, if you like, as part of the family and the community. But ultimately, as a clinician, my responsibility is for the patient, and you need to get to know them as well as you can, and you need to get to know who else is in the room, who's not in the room. So I use Zoom a lot with the expert, the health expert that might be the GP in Melbourne who can't come up to Albury to see him, or the daughter who's a nurse. So you encompass everybody, but importantly, adequate assessment yields appropriate care. So to bring geriatric oncology back in, the system needs to change to adequately assess the person in the chair holistically, and that then you can care for them appropriately. So that's my message is that, and by doing that, you have to ask the patient what they want. And sometimes, let's say that a study was done of older patients over the age of 65 having treatment, palliative treatment for cancer, and they were asked, what's more important to you, living longer or preservation of independence? And for about half the patients, they said, preservation of independence is the key. So we don't know that unless we ask them. So as an individual dealing with an individual patient, you need to get to know them more, as we discussed at the very beginning of this discussion.
Thanks, Christopher. That underpins the work we do, certainly, is what matters to the patient. What matters to the patient is key, isn't it?
What matters most?
Yeah, that's right. Great. Thank you for bringing that up. John, would you like to give us your view on society's contracts, obligations?
Yeah, I thought Grant said it very well, actually. So health is a right and not a privilege, as we've seen it in some other countries that we sometimes put up as models of how we might want to see things work. But in Australia, it is a right, and that's the way it works. I think at the level of the clinician, I would say the social contract is to expect and for the clinician to understand empathy. For me, that's what I. So it doesn't. That's the sort of walk in the room and feel what it's like to have waited 10 minutes every time they see me. Someone's waiting and delayed, whether it's as simple as that, or whether it's empathy around some of their symptoms and problems, or family issues, or indeed access to drugs and treatment. So I think that's what we as a community should have a right to expect of our medical profession. And I think in oncology, largely I would say that is done fantastically well. And the people on this panel illustrate that. I think Grant said it, though, really hit the nail on the head at a societal level.
Thanks, John. Absolutely. Claire, what are society's obligations to Australians living with cancer?
Well, having regard to human dignity and always making sure that you treat everyone. Yeah, having regard to human dignity, so always having regard to the person who's with you mentally, and communicating knowledge. So everyone has a right to the best expertise that can be found for them. So in that regard, we've initiated the Australian Rare Cancer Portal so that patients with a rare cancer and their doctor can access expertise about that cancer from anywhere in Australia or overseas. So a patient can go to their cancer specialist and ask their cancer specialist to register with the Rare Cancer Portal, and within a couple of weeks they can receive a letter back about their case from experts within Australia or overseas. And that prevents doctors having to, lose touch with their patients, or patients having to go doctor shopping. And we've had really good feedback from patients and from doctors. So we just have tried to assist Rare Cancers Australia so that they don't have to be the ones shopping for the experts. But it's really there to try to make sure that patients don't feel like they're swimming and having to do that searching for themselves. So I think that comes back to human dignity, because we want to make sure that every patient with cancer in Australia feels that they have the right to get the best information about their cancer. And that's my contract with Australians with Cancer.
Absolutely. That's really reassuring, Claire. Your work in helping people to tap into the brain's trust is superb, really, really important. Thank you. We just have a couple of minutes left to close out, and I know that Richard would like to say something. Thank you, panel, from my perspective, very much for your generous contribution. Thanks, Richard.
Yeah, hi everyone, and thank you to the panelists, and thank you to the audience. We've run a lot of these workshops, and this is by far the one of the best, most inspiring, and most interesting and extraordinary. I think we peaked somewhere north of 140, heading towards 150 people on the panel, which is just brilliant. I'd like to just personally thank each of the four panelists, plus the wonderful cameo from Fran Boyle, which was sensational. But each of these people spend every day trying to look after patients, and they have brilliant minds, brilliant careers, and to get an hour from them is a privilege. So thank you, guys. Thanks also to Christine, who's we've all done this job of trying to wrangle a panel in the middle of a virtual thing, and I suspect she'll be off for a Valium and a lie down after this. It's hard work. I'd also like to thank the rest of the RCA team. This sort of thing is a bit like a sausage. You don't really want to see how it's made, but I can assure you that there are a whole number of people who've been running around looking after chats, looking after the technology, looking after the way in which the panelists and everybody's presented on screen. It's not an easy thing to do, and we try really hard, and the guys spend a lot of time and effort. So a huge thank you to them. And just because we're masochists, we're doing it all again next week, except this time instead of clinicians, we're going to have the chief executives of 6 of Australia's leading oncology medicine providers, leading pharmaceutical companies with a focus on oncology. I won't bother to name them. They'll be all in where you've registered, but they will be a sensational chat. And as we went through that talk today, we started to morph from the clinical care to the health system and how patient rights and what are reasonable expectations in that space. And I think that's going to make for a fascinating chat. I think part of our problem is that we have For those of you who are old enough to remember the book Catch-22, we have a Catch-22 system where we almost make it impossible for a commercial enterprise to bother to apply for reimbursement in Australia in certain circumstances. And then when you ask the government about it, they say, well, we haven't had an application. And that to me is very similar to the Catch-22. My last point, as part of our research into this whole project and the rights and roles of patients, we're inviting all Australians who've experienced cancer directly or via a family member to complete a short 4-minute questionnaire to help us understand what matters most to you and to your loved ones. So the link should now be in the chat. It's also available on our website, but our aim is to get hundreds upon hundreds of responses to this survey so that it comes with the substance of numbers. So if you could do that, we'd be really grateful. Thank you all for coming, and hopefully we can all do it again next week and we can bust this number. It should be an absolute ripper session next week. I'm so excited about that. And thanks again to our panelists today. They've been brilliant, and we'll see you all soon. Thanks, guys. Bye.